Good evening, good afternoon, and good morning to all of you, and a warm welcome from APAAACI. On behalf of the APAAACI Board of Directors and all our national member societies, our junior member chairs, Lu Zhang and Agnes Leong, our JAFCA steering committee, we are proud to bring to you today this very important masterclass on chronic urticaria and atopic dermatitis. And this particular masterclass is led by none other than our own JAFCA leaders. So it gives me great privilege to let you know the learning objectives of this very important masterclass. So this masterclass will actually highlight the latest global recommendations on the differential diagnosis and the management of chronic urticaria, with special aspects on the perspectives of Asia Pacific as related to chronic urticaria. It will also highlight the pathomechanisms and the characteristics of atopic dermatitis in children and the relationship between AD and food allergies in children. And finally, the third talk will help you understand the mechanisms of Autosomal Recessive Hyper-IgE Syndrome in a patient with severe atopic dermatitis, the roles of genetic testing in the diagnosis of this disease, as well as the use of biologics in its treatment. To start this, I would like to introduce our moderator. It's my great privilege and honor to welcome Professor Marisa T. Recto, who's the immediate past president of the Philippine Society of Allergy, Asthma, and Immunology. Professor Recto is a professor of allergy and immunology at the University of Philippines, Philippine General Hospital. She did her pediatric residency and training and a fellowship at the section of adult and pediatric allergy at the UP-PGH, as well as the postgraduate training at the section of pediatric allergy and pulmonology at the University of Padua in Italy. Dr. Marisa Recto, as I said, is the immediate past president of the Philippine Society of Allergy, Asthma, and Immunology, PAAACI, and she's also a member of the YACI, as well as of the American College of Allergy, Asthma, and Immunology. And she is also the scientific chair of the upcoming APAACI 2022 PAAACI at 50, which will celebrate the Philippines' 50th anniversary or the golden anniversary. So it's my pleasure to welcome Professor Marisa Recto to moderate this webinar.
Thank you very much, Professor Ruby Pawangkar. It's indeed an honor to be part of this masterclass with the very exciting and relevant topics on urticaria and atopic dermatitis. So we hope to learn from our young members who are updated and want to keep us abreast with the latest on these conditions. So before we start, I'd like to give you some webinar housekeeping. This webinar will be recorded. It will be uploaded on APAACI TV at www.apaaci.org and all other APAACI Learning online platforms. Second is all the participants will be muted by the organizer upon entry, and there will be poll questions during each lecture, and all attendees are welcome to vote for the correct answers to convert this to an interactive session. The Q&A feature provides an opportunity for attendees to enter questions for the presenters, and at the end of the webinar, we will get the speakers to respond. Due to the time restrictions, any questions left unanswered will be uploaded into www.apaaci.org with the answers from each speaker. So all questions, please channel it through the Q&A box. Okay, so we can now proceed with our program proper. And I'd like to present the first speaker, He is an allergist and immunologist at both Eastern Health and Monash Health in Melbourne, Australia. He's passionate about looking after patients with allergic and immunological disorders into clinical teaching and getting involved in clinical research. May I present now Dr. Jason Falk, who will now talk on the International APAACI Euroguide Derm APAACI guidelines for the definition, classification, diagnosis, and management of urticaria. So may I request Dr. Falk now to share his screen.
Hello, everyone. My name is Jason Falk. Thanks for having me at this symposium. I've been given the task to talk about the International APAACI Euroguide Derm APAACI guideline for the definition, classification, diagnosis, and management of urticaria. So this update and revision of the guideline for urticaria was developed based on the methods recommended by Cochrane and the GREAT Working Group. And it is a joint initiative between the dermatology section of the APAACI, the Galen with the UK and ACARE centers, the European Dermatology Forum, as well as APAACI. I have no conflict of interest. So in the next 20 minutes, I'll be talking about what's new in this 2021 guideline with further addition to the one which was last published in 2018. We'll learn about the latest global recommendations on the differential diagnosis of chronic urticaria, and to learn about the global recommendations on the management of urticaria in a stepwise approach. And we'll highlight a few papers looking at perspectives of urticaria in the Asia-Pacific region. Before we start, it is important to be familiar with the definitions of urticaria, which is characterized by development of wheals and hives or injury edema or both. Wheal is actually a sharply circumscribed superficial central swelling of variable size and shape, almost invariably surrounded by reflex erythema. It has an itching or sometimes burning sensation. It has a fleeting nature, with the skin returning to a normal appearance within 30 minutes to 24 hours. Whereas angioedema is characterized by a sudden erythematous or skin-colored deep swelling in the lower dermis and subcutaneous or mucous membrane, with tingling, burning, tightness, and sometimes pain. It has much slower resolution compared to wheal, and it can take up to about 72 hours. So, urticaria can be divided into acute urticaria, which is characterized by development of wheals, hives, angioedema, or both, not more than 6 weeks. Whereas chronic urticaria has a duration of more than 6 weeks. And the spectrum of clinical manifestations of different subtypes of urticaria can be very wide. It's not uncommon to see 2 or more different subtypes in an individual, which can coexist. And in chronic spontaneous urticaria, it can be due to known or unknown causes, but essentially it can be divided into type 1 or type 2B, and type 1 is considered as an autoallergy type with IgE autoantibodies to self-antigen, and type 2B is believed to have an autoimmune phenomenon with mast cells directed activating autoantibodies. Whereas chronic inducible urticaria or physical urticaria has different subtypes as well, including symptomatic dermographism, cold urticaria, delayed pressure urticaria, solar urticaria, heat urticaria, contact urticaria, cholinergic urticaria, and the list goes on. The aims of the diagnostic of worked out. There are 7 aims, which can be quite easily remembered with 7C as a mnemonic. So it is important to confirm a diagnosis and to exclude other differential diagnoses. In the subsequent slides, we'll be going through a list of differential diagnoses which are important to be considered. And And when it comes to cause, look for indicators of different types of CSU. This is important because in type 2B, CSU is characterized, there's a tendency to be associated with high CRP, low eosinophil count, low basophil count, low total IgE count, elevated IgG, thyroid peroxidase, and so on. Not forgetting, it's important to explore any cofactors, which can be potential triggers or aggravators. We know emotional stress can be associated, has been reported up to a third of the patients suffering from CSU. And of all the medications, non-steroidal anti-inflammatory drugs or NSAIDs have been implicated as the most commonly encountered drug, aggravating underlying CSU. And it's important to explore the comorbidities, including concomitant chronic inducible urticaria, coexisting autoimmunity, allergies, and not forgetting mental health, especially associated with depression and anxiety. Next, it's important to explore consequences, including identifying problems with sleep, distress, sexual health, work, and social performance. And it's important to explore the components involved in potential biomarkers or predictors of treatment response. And we know that in recent papers, concomitant chronic inducible urticaria, high urticaria activity score at baseline, elevated CRP, concurrent angioedema, and quite a few other factors have been implicated as poor response to antihistamines. And lastly, when assessing patients in the clinic, it's important to understand the cause of a disease by monitoring CSU activity, impact, and control by using different patient-reported outcome measures such as UAS7, and the UCT, or chronic urticaria quality of life questionnaire, and so on. So because there's a spectrum of conditions which can manifest with wheals and or angioedema, it is important to be familiar or to think about certain conditions which can resemble or mimic chronic urticaria. And one of the important examples is maculopapular cutaneous mastocytosis, also known as urticaria pigmentosum, which is characterized by a positive Darius sign, and indolent systemic mastocytosis with skin involvement, and not forgetting urticaria vasculitis, which essentially is a painful condition, may be associated with arthralgia and pigmentation when the hives disappeared. And bradykinin-mediated angioedema, which is a non-mast cell-mediated angioedema, and the example is hereditary angioedema, and also exercise-induced anaphylaxis, which may be wheat or non-wheat dependent. And another subtype, which is probably more prevalent in the pediatric cohort, is the autoinflammatory syndrome, such as cryopyrin-associated periodic syndromes, CAPS. Examples are Markowell syndrome, familial cold autoinflammatory syndrome, and not forgetting also Schnitzer syndrome. It's characterized by recurrent urticaria rash, monoclonal gammopathy, fevers, bone pain, muscle pain, joint pain, and lymph node enlargement. And also there's an entity of angioedema called Glitcher syndrome, which is characterized by episodic angioedema with high eosinophil count. And there is also Wells syndrome, which is granulomatous dermatitis with eosinophilia and eosinophilic cellulitis, and also the pre-bullous stage of a bullous pemphigoid, as well as adult onset Still's disease. So if we look at this diagram, which is taken from the paper itself, and essentially most of the diagrams in this talk has been taken from the paper that was published last year. You will look at the different pathway addressing different questions related to either wheals or angioedema from the history itself to through the diagnostic test and leading to different pathway involved explaining different the pathogenesis of the symptoms, and which may be interleukin-1 pathway if it's associated with autoinflammatory syndrome, or it may be histamine and other mast cell mediators if it's related to chronic urticaria or chronic inducible urticaria. And lastly, the bradykinin pathway, if there's a concern about hereditary angioedema, acquired angioedema due to acquired C1 inhibitor deficiency or drug-induced, drug-related angioedema, such as ACE inhibitor related. So the guideline recommends for the CSU counterpart, differential diagnosis should be considered in all patients with signs and symptoms suggested of chronic urticaria based on the guideline algorithm. Acute urticaria itself is a self-limiting process, so it doesn't usually warrant further investigations. Whereas for CSU, there's limited investigations can be performed, at least with basic tests like differential blood count, looking at eosinophil, basophil, inflammatory markers such as CRP, ESR, total IgE, and IgG anti-thyroid peroxidase, antibody, looking at in the presence or absence of Graves' disease or Hashimoto thyroiditis, they are considered appropriate. And obviously, there are further diagnostic measures based on patient history examination, especially in long-standing uncontrolled disease based on the history and clinical assessment, which can be individualized. Whereas for CIndU, provocation testing to diagnose, there are different devices that can be used, which is beyond the scope of this talk today. So the management of urticaria, the philosophy is to treat until the disease is gone. So it's important to search for an elimination of underlying causes and also avoidance of eliciting factors, including non-steroidal anti-inflammatory drugs, cold exposure, warm exposure, physical exercise, sun exposure, especially in the setting of solar urticaria, also tolerance induction, and use of pharmacological treatment to prevent mast cell mediator release. And the principle of treating urticaria is based on a step up and step down approach, which involve assess, adjust, act, and then reassess. So you treat as much as needed or as little as possible because activity of the disease varies over time. And then you can step up or step down the treatment according to the cause of the disease itself. And to adjust and to assess the problem or to assess the clinical problem solving. It involves diagnostic procedures, assessing comorbidities, like what we talked about before, assessing severity by using different patient reported outcome measures, and also by adjusting treatment plan by stepping up if inadequate control, or change if side effects occur, or step down if the symptom is free for 3 to 6 months. And by using a certain score like urticaria control score, you can adjust the treatment accordingly. So the recommendation is aiming at control symptom control in urticaria, considering as much as possible the safety and quality of life of each individual patient, and also advising patients with CSU to discontinue medication that is suspected to worsen the disease, such as in the setting of ibuprofen exacerbating CSU. So as the audience of this symposium comes from different regions of the world, so I've highlighted a few examples of second generation H1 antihistamines, and obviously they are used in different regions, and they may not be used in, they're not available in other parts of the world. So the examples that we'll be looking at are bilastine, cetirizine, desloratadine, ebastine, fexofenadine, levocetirizine, loratadine, and ripetadine. In my practice in Australia, we commonly use cetirizine, fexofenadine, and loratadine. So the current guidelines recommend using a second generation H1 antihistamine as a first-line treatment for all types of urticaria. And this can be updosed up to 4-fold in patients with chronic urticaria if the patient is unresponsive to a standard dose as a second-line treatment before other treatments are considered. And it's also suggested that they can be taken regularly for the treatment of patients with chronic urticaria. So the guidelines suggest against using different H1 antihistamine at the same time, and it's recommended against using higher than 4-fold standard dose H1 antihistamines in chronic urticaria. What if it fails to control a patient's symptoms? And the next online is actually omalizumab. If the patient is unresponsive to high-dose second-generation anti-H1 antihistamine. So omalizumab is an anti-IgE treatment. It prevents IgE from binding to IgE receptor on mast cells and basophils. If it fails, we can suggest using cyclosporine if unresponsive to high-dose second-generation antihistamine and omalizumab. But obviously, cyclosporine has a kind of an inferior side effect profile compared to the other list of medication. It's recommended against the long-term use of systemic glucocorticosteroids in chronic urticaria, but you may consider a short course of rescue systemic steroids in patients with acute exacerbation of chronic urticaria. So this is another summary taken from the paper, which is in a way is self-explanatory. It starts with standard dose second-generation antihistamine, and if needed, it can be updosed to 4 times. And if inadequate, after 2 to 4 weeks or earlier, and if the symptoms are intolerable, we'll move on to the next step, which is adding omalizumab. And the dose of omalizumab can even be increased or given in a shorter interval if needed. And failing which, you can consider adding a second-generation. You can consider adding cyclosporine. Switch to cyclosporine as the next line of treatment. With this, I will use the remaining few minutes to talk about a few papers published in the last 12 to 18 months in the Asia-Pacific region. And this paper looks at association between the severity of CSU and sleep-disordered breathing. And it is found that sleep-disordered breathing severity is correlated with the severity of the urticaria independently of a body mass index. And CSU symptoms improved by the treatment of sleep-disordered breathing. There's also a review paper published in the journal Cells, which looks at the role of coagulation and complement factors for mast cells activations in the pathogenesis of CSU. And it discussed the role of vascular endothelial cells, leukocytes, and so on tissue factor-induced activation of skin mast cells and peripheral basophils. And there's also a paper looking at mast-related G protein couple receptor X2, which is MRGPRX2. The level is found to be elevated in patient with severe CSU when significantly correlated with UAA7. There's also another paper published last year looking at screening for autoimmune comorbidities in patients with CSU, which tests to whom. So it has been reported in different literature. Thyroid diseases are the most commonly reported autoimmune diseases accompanying CSU globally. This is actually echoed in other studies in 2017 paper and the 2021 paper looking at autoimmune thyroid disease at higher risk of developing CSU. And it has also demonstrated that it may be related to type 2B, which is autoimmune immunity of a CSU with high UAA7, presence of angioedema, and being unresponsive to omalizumab. Lastly, this paper looks at predictors of response to oral medications and low histamine diet in patients with chronic urticaria and explore different markers as mentioned in the slide. Yeah, with this, I'll end my talk and thank you for your attention.
Thank you very much, Dr. Phoc, for that very updated and comprehensive discussion on the approach to the diagnosis and management of chronic urticaria. So it is now my pleasure to present the next speaker. He is from the Allergy and Clinical Immunology Unit at the University Medical Center of Ho Chi Minh City. He's the HCAACI Scientific Secretary and part of APAACI's JMG Steering Committee and WOW's JMG Steering Committee. So to talk on pediatric atopic dermatitis and its relation to food allergies. So this is a very exciting and relevant topic. May I now present Dr. Pham. Take it away, Dr. Pham, and please share your slides.
Yes, thank you, Professor Mauricia, for your kind introduction. And I'd like to share my slide. So, hello, everybody. Thanks to APAAACI for inviting me to have a talk in this very first masterclass of CHAFCA. And I'm so excited to share, to learn, and to discuss with you about this very relevant disease in allergies unit about pediatric atopic dermatitis. So today we discuss with you about the characteristic of pediatric atopic dermatitis and its relation to food allergy. I have no conflict of interest to declare. So there are 3 learning objectives that I hope you could achieve after my presentation. First is to understand the pathological mechanisms of AD. Second is to understand the characteristic of AD in children. And last is to get a better understanding of the relationship between AD and food allergies in children. So let's move to the first part about the pathological mechanism of AD. So we know that AD is one of the most common allergic disease in children, and which could affect up to 20% of children. And among the children with AD, 60% of cases occur in the first year of life. And AD is a chronic with fluctuating course, and it's characterized by itchy and eczematous lesions. And those lesions vary according to the stage of the disease and the age of the child. And the AD flares could be triggered by many factors, including extreme climates like hot climate, cold, humid, or dry. All of them can trigger AD symptoms. Besides the climate condition, foods, medications, as well as skincare routine can also activate the AD symptoms. Although the mechanism of AD is complicated and not yet fully understood, it has been long known that there is an impairment in AD skin or the skin barrier impairment and a dysfunction of immune system, immune response. So these 2 key factors interact and cause the inflammation in the skin. The expression of important proteins such as the ficlacrine or antimicrobial peptide and serine protease inhibitors are decreased, while several other proteins like serine protease and tight junction disorder were increased, lead to the loss of epidermal integrity and trigger the inflammation by activating the immune system underneath the skin. And the immune response is driven toward the Th2 response with the sensitization to the allergen, which is supposed to penetrate through the impaired epidermal layer. Ficlacrine monomers. Ficlacrine is very important protein in the pathological mechanism of AD. And the ficlacrine monomers are produced from the proteolysis of its precursor protein, the profilacrin, during the differentiation of keratinocytes in the epidermis. So the main function of the ficlacrine is to maintain the integrity of the stratum corneum by aggregating the keratin filament and to form a cornified envelope of the corneal site. And moreover, ficlacrine proteolysis will produce natural moisturizing factors, which is the pyridine carboxylic acid and urocanate acid. These factors help maintain the moisture of the skin and the acidic environment of the skin. And study shows that the loss of function of ficlacrine due to mutation is associated with the early onset and more severe phenotype of atopic dermatitis. It also found to be associated with the co-infection with bacteria, for example, Staphylococcus aureus, or a virus, for example, the herpes. And the study also showed that people with the loss of function of ficlacrine have the increased risk of developing asthma and food allergy. And this is one question for you. So in your opinion, what is the factor could induce a filacrine downregulation in atopic dermatitis patient. Please select a correct answer. First is filacrine mutation. Second, TX2 and TX17 cytokines. Third is the environmental factors. And last one is all of the above. Please vote. Okay, I can see here, most of you, 80% select the D, all of the above, and some of you select filacrine mutation, and very few selected TX2, TX17 cytokine, and environmental factors. So let's see the answer in the next slide. The study showed that 40% filacrine mutation carrier do not develop AD. And filacrine mutations are only found in maximum 50% of patients with AD. So not all patients with AD have filacrine mutation, and not all mutation carriers develop AD. However, the study showed that in the skin of patients without filacrine mutation, the expression of filacrine in the skin was suppressed, was decreased. So there must be another factor induced the downregulation of filacrine in the AD skin. And studies show that TX2 cytokine played a role in downregulating the expression of filacrine. And not only filacrine, other proteins that played a role in constructing the cornified envelope in the corneal side is chloroquine and involucrin. And the expression of those proteins in the skin, in the AD skin, were also decreased, as you can see in those figures. And moreover, the tight junction protein, for example, claudin-1, occludin, and so on, also were downregulated in the skin of the AD patient. And many studies show that the TX2 cytokine plays a role in downregulating the expression of filacrine, involucrin, logrin, as well as the occludin. And this table summarizes the factors that can reduce the level of edematous filacrine in the skin. We can see here the filacrine mutation, the environmental exposure, for example, low humidity, sunburn, skin irritants, tap stripping, and so on, can also affect the expression of filacrine. And especially the cytokines from the TX2 response, like interleukin 4, interleukin 13, cytokine from TX17 response, like interleukin 17-8, interleukin 25, and other cytokines, and also can downregulate the expression of filacrine. And even infection with microorganisms, for example, HPV, fungus, or several bacteria also can suppress the expression of filacrine. And we can also see here the use of topical medicine like dithranol, retinoic acid, or the long-term use of corticosteroid can also suppress the expression of filacrine in the skin. So altogether, we can see many factors can affect the expression of filacrine in AD skin, not only filacrine mutation. So the answer should be D, all of the above. Next, I would like to move to the second part, the characteristic of pediatric atopic dermatitis. Traditionally, eczema lesions are classified into acute with oozing, edema, and erythema, or chronic lesion with dyspigmentation, cirrhosis, and lichenification. However, because AD is a chronic relapsing condition, so both types of lesion, acute and chronic, can coexist during the flares. And pruritus is a hallmark of AD, and excoriation secondary to stretching are often present. And we should note that the location of AD lesions is changed by the age of the child. In non-mobile infant, the lesions are found in face and scalp. In crawling infant, the lesions are found in the extensor surface of extremity, in the trunk, face, and neck. In older child and adolescent, we can see the lesions in the wrist, ankles, cubital fossa, popliteal fossa, and neck. And in adult, the eczema could be limited in hand and foot. We also perform a survey to investigate the AD characteristic in Vietnamese children under 18 years old. We found that 90% of AD cases in children were diagnosed at the age of under 5 years old. We can see here 23% from under 1 month, 50% from 1 to 12 months, 13% from 1 to 3 years old, and 3% in 5 years old. Under 5 years old. And the data is quite similar with the study from other continents or other countries. Regarding the lesion location, in overall, the lesion were found mostly on the cheeks with 60%, on the leg or the arms with 40%. When we analyze the distribution of the lesions according to ages, we found that the children under 12 months have the lesion on the cheeks. And when they get older, the lesion appear more frequently on the arm and hands, or legs and foot. So we can see here the AD lesion change location according to ages again. However, some parents could think that their children get worsened eczema when the lesion locations are changed. So the doctors should aware them about the change of the lesion characteristics so that the parents don't need to worry too much when their children get older and when they see the location of AD lesion change. Regarding the trigger of AD in children, 62%, we can see here, 62% parents did not know the exact trigger of AD or thought that it was spontaneously exacerbated. Besides that, the common suspected trigger were extreme weather, like extremely hot, cold, or dry air can trigger the atopic dermatitis, followed by milk and dairy product and other food. According to ages, besides the spontaneous flare-up, the common trigger is milk and milk products in the children under 5 years old, especially under 12 months. Under 12 months. And meanwhile, extreme weather conditions such as hot or cold weather are common trigger in all ages. So this data also suggested that food is not the only trigger of AD. Indeed, many other factors could provoke AD symptoms, or even AD will spontaneously flare without any obvious causes. So the doctors also should address the issues to the parents to help them understand more about the condition of their children. And next is about the association of food allergen sensitization in AD. This is very well-known atopy march showing that AD and food allergy could develop in the early life. After that, when the AD incidence goes down, food allergy and respiratory allergy diseases, for example, rhinitis or asthma, develop. So the study suggests that the impaired skin of AD is the root where the sensitization to environmental and food allergen occurs. However, we should not hear that the AD with early onset is strongly associated with the food allergy. So the food sensitization in the early life could not only occur through the damaged skin, but also by other routes, for example, through the gut. Food allergies are found to be associated with AD in numerous studies where the prevalence of food allergy in AD patient is around from 30 to up to 60%. And another systemic review published in JCI in 2016 report that the prevalence of food allergy was 6 times higher in children with AD compared to those healthy at the 3 month of age. And this is a very recent the best practice published by a task force of Quattro AI, a very recent publication in JCI. And there are several key messages that I would like to share with you. First, food allergy could trigger AD symptom, but it's rarely a cause of AD development because many patients, many parents, even the doctor, they think that food allergy caused the AD development. That is not like that. Food allergy can trigger the AD symptom, but it's not the cause. The second message is that more than 90% moderate and severe AD children were sensitized to at least one common food allergen, and over half of those has reactivity to food. And IgE testing may not identify trigger food. So we can consider food allergy in children with severe AD. We can do IgE test or skin prick test, but we have to perform the oral food challenge to identify the trigger food. We should not only based on the result of IgE testing or skin prick test. And the last one, a very important message, is the elimination diet could increase the risk of IgE-mediated food allergy symptoms, including anaphylaxis and malnutrition. So this is the second question for you. In your own experience for our study, what are the 3 common sensitized allergens in Asian children with atopic dermatitis? Please select the 3 answers that apply. It's not correct or incorrect, not true or false. It's based on your experience or the study in your country, in your area. Please select the 3 common sensitized food allergens in Asian children. Okay, I can see here most of you selected cow's milk and egg, and 50% of you selected peanut, and then seafood with 40%, soy and beef under 20%. So maybe all of you agree that cow's milk, egg, and peanuts are the most common sensitized food allergen in Asian country. So let's see what our data bring to you. We performed a study in 2018 to see the sensitized allergen in AD children under 18 years old. And we found that how does mite and a protein of the milk, cow's milk, bovine serum albumin were the most common sensitized food allergen. And after that, in 2021, we performed another study and focused on children under 3 years old who were diagnosed with AD. We measured the serum-specific IgE antibodies to 30 food allergens using immunoplot. And we found that 87% of the children were, AD children were sensitized to at least 1 food allergen. 46% were sensitized to 1 to 4 allergen, 22% were sensitized to 5 to 10 allergen, and 20% of them were sensitized to more than 10 allergen. We also found a relationship between the AD severity and the number of sensitized allergen. As you can see here, the children with moderate and severe AD had a significantly more number of sensitized food allergen compared to those with mild AD phenotype. We also found the same finding with the best practice that I showed you, that 91% of the moderate and severe AD children were sensitized to at least 1 food allergen. And we can see here the egg white, cow's milk, almond, beef, and egg yolk were the most common sensitized allergen in our study population. We can see here peanuts is under 20%. In my own opinion, in case of Vietnamese population, peanuts is not a common sensitized or the food allergen in children with food allergy or even though with atopic dermatitis. Other allergen also here, and the sensitization rate under 20%. And again, we can see here the score rate has a positive correlation with the number of sensitized food allergen. And one of the most important questions is, could moisturizer prevent AD development? So this is another question for you. What factors could this is the first question. Please move to the last questions about the role of moisturizer on preventing atopic dermatitis. Sorry, maybe something wrong here. So I would like to stop this poll and let's get started with the slide directly. So next slide. Actually, in 2014, 2 studies were published in the same journal, JACI, showing that the applying of moisturizer could prevent the AD development. We can see here, this is the study in Tokyo, in Japan. The newborns were divided into 2 study groups, intervention group with daily moisturizer application and a control group. And the results showed that the risk of AD development in intervention group were significantly lower than in control group. And the second study published in the same journal, the same volume, were performed in UK and US, and the newborns also were divided into intervention group with daily moisturizer application and control group. And they also found that the prevalence of AD children in intervention group was half of that number in the control group. So those studies found that application of moisturizer helps to prevent the AD development. However, in 2020, another study with a bigger, larger study population showed opposite data. This is the study, multi-center RCT performed in Sweden, and the newborns were randomly assigned into skin intervention group where the babies was applied moisturizer more than 4 days a week. The food intervention group where the babies was only introduced the food like peanut, cow's milk, wheat, and egg. The combined group combined skin and food intervention, and the control group. And the primary outcome was the eczema prevalence at 12 months of age. And the data shows that there were no significantly different in terms of the AD prevalent, the AD patients in 4 study groups. So application of moisturizer in high-risk newborn did not help prevent the AD developing. The next study, also published in Lancet 2022, is a multi-center RCT performed in UK. Newborns were randomly assigned into emollient application group and standard skincare advice. And the primary outcome is eczema prevalent at the age of 24 months. And they also found that the prevalence of AD children in 2 study groups were not different. So again, the role of moisturizer application in preventing AD development is not clear. And this is a very recent study published in JHCI in 2021. The study called Inquiry about tolerance. And this study investigated the association of the frequent moisturizer application and food allergy in children. In this study, 1,303 infants at 3 months old in England and Wales were recruited, and a survey on frequency of moisturizer application in the first 3 months of life were conducted. And the findings showed that the food allergy prevalence was positively associated with the frequency of moisturizer application, which means that moisturizer application was associated with an increased risk of food allergy development. When looking at the 2 separate groups, the group with the no visible eczema and the group with visible eczema, the same findings was observed. So these findings were first shocked me because we all doctors usually advise the parent to apply the moisturizer for baby, especially the baby with atopic dermatitis, to help manage the AD. However, this study showed that if we apply the moisturizer more, so it will increase the risk of food allergy. But the author proposed 2 possible explanations for this finding. First, the moisturizer laid around as a vehicle to facilitate the penetration of environmental and food allergen through the skin. And the second explanation is that some substances in the moisturizer, for example, the sodium lauryl sulfate SLS, could damage the epidermis and thereby exposing the skin immune cells to the allergen, leading to the sensitization. So this finding prompts to another thinking that we have to carefully select the moisturizer for the baby, and actually more studies are needed to understand the underlying mechanism of this finding. So in conclusion, the immune dysfunction and impaired skin barrier are the key pathological mechanism of AD. The type and location of AD lesions in children are changed over time. The triggers of almost AD flares are unknown, although extreme weather and dairy products are believed to induce AD flares. The food allergy could be considered in moderate to severe AD children, but trigger food should be carefully identified. And lastly, the roles of moisturizer in preventing AD development are still controversial and more data are needed. And I would like to send my thankfulness to my colleagues, Dr. Trần Lê Hương Nguyên, Dr. Trần Hoàng Kim Tú, and Ms. Lê Kiều Minh to join in those research. And thank you very much for your attention.
Thank you very much, Dr. Pham. That really was a very updated report on atopic dermatitis and food allergy. You know, these are conditions that really affect a lot of our patients, and we have to really know all these updates in order to provide good care for our patients in the clinic. So we look forward. There's a lot of questions for the doctors, but before we go there, I would like now to turn over the floor to the next speaker. This is Dr. Nguyen Hoang Kim Han, who's an internal medicine resident at the Vinh University College of Health Sciences in Vietnam. So she's actually one of our youngest presenters, and she will be talking about a case report on atopic dermatitis in hyper-IgE syndrome and the role of biologics. So this is quite unusual, very relevant topic. So now, Dr. Nguyen, can we now have your slides? Please share them.
About that, and thank you so much for your introduction. So good afternoon, my name is Kim Han. I'm an internal medicine resident from Vinh University, and as you can see that I'm just a newbie in allergies, asthma, and not in clinical immunology. So today is in my great honor to share with you a case report about atopic dermatitis in hyper-IgE syndromes and roles of biologics. My supervisor and also the primary doctor in this case, Dr. Nguyen, also be here to participate in further discussion. There are three learning, so there are three learning objectives today. The first is to understand the mechanism of Autosomal Recessive Hyper-IgE Syndromes in a patient with severe atopic dermatitis. The second is to determine the roles of genetic testing and AR-HIES syndromes. And the third one is to describe the biologic use in the treatment of that. So let's begin with the case report. This is a 30-year-old Japanese male living in Vietnam. Can you go to the next slide? He admitted to the hospital because of vesicular eruption and high fever for 5 days. He first noticed the multiple vesicle in the right axilla, and then quickly spread to his chest, abdomen, back, and arm. His lesions were itchy and painful also. He also had episodic fever at very high temperature, about 40 degrees, and chilling. So next slide, please. His past medical history was significant, with severe chronic atopic dermatitis from childhood. He also had a similar episode of skin lesions 10 years ago without fever and chills. At that time, he didn't have a clear diagnosis, and the lesions resolved with topical medication within a month. He was an office staff. He sexually active with one partner, and no recent traveling, no smoking, alcohol, and illicit drugs use. He had a severe food allergy from childhood with many different kinds of food, such as egg, cream, seafood, and orange. His past medical history, medication, and family histories is not significant. So next slide, please. Yeah, on physical examination, he was in acute mild distress with 40 degrees of fever. All the vital signs were within the normal limit. He had multiple axillary lymph nodes on both sides. The size is about 2 centimeters by 3 centimeters. They are tender and mobile. The HEE anti-cardiovascular, respiratory, and abdominal examination was normal. On skin examination, there are multiple vesicles and pustules on erythematous base in the chest, abdomen, back, and arms. Can you go to the next slide, please? He also had eczematous lesion with dry, flaky erythematous and thickening skin. His eczema area and severity index was 22.7, which means that he had severe atopic dermatitis. So we did the immunologic assessment, and the result was very interesting. You can see here the CBC. Can you go to the next slide, please? Yeah, you can see here that the CBC showed hypereosinophilia. The IgE level was 33 times more than the upper normal limit, while the serum IgM level and circulating T cells was decreased. Herpes simplex virus infections was confirmed with positive PCR result, and screening for malignancy with CT scans and serological markers show no significant abnormality. Can you go to the next slide? Yeah. We also did the atopic screening test. And as you can see here, high level of specific IgEs against several allergens was detected. And the most notable was DP, DF, cat, egg white, and so on. And according to the clinical and laboratory findings in our patient, we think about hyper-IgE syndromes so that we focused on the gene set related to hyper-IgE syndromes, including STAT3, DOCT8, and some other genes. The whole exome sequencing was done, and in STAT3 genes had no mutation. DOCT8 gene had 2 missense variants, and SPINK5 genes have 5 missense variants. So with the confirmatory genetic analysis, the final diagnosis was eczema hepaticum on autosomal recessive hyper-IgE syndromes. Supported treatment including acyclovir, methylprednisolone, moisturizer, battery elimination, and anti-IgE therapy with omalizumab. After 3 months of the treatment, the patient had a significant clinical improvement and no side effect. You can see here, this is the skin lesion before and after treatment. The eczema area and severity index decreased from 22.7 to 10.8 after 3 months. And that is the case report. In conclusion, a patient with recurrent viral infection, severe allergies, eosinophilia, and markedly elevated IgE should be investigated for AR-HIES syndromes and for mutations in DOCT8 genes. Supportive treatment based on management of infection, skin care, and elimination of dietary allergens is essential. Anti-IgE therapy with omalizumab should be considered as a targeted treatment for these syndromes. So now we will move to the second part of the presentation for further information about atopic dermatitis in hyper-IgE syndromes and roles of biology. So first, let's start with the mechanism of autosomal recessive hyper-IgE syndromes in a patient with severe atopic dermatitis. Can you go to, to the next slide? Okay, thank you. So we all know that the IgEs is integral to the pathogenesis of allergic disease. However, the elevated total serum IgEs is not specific to allergic disease. So you can see here that so many different causes that can increase the IgE level, including allergic disease, immunodeficiency, parasitic and viral infection, inflammatory disease, and some malignancy. And we can see that IgEs also can increase in patients who have atopic dermatitis. And the triad defined by increased IgE level, eosinophilia, and atopic dermatitis is very common in many allergic diseases. So can you go to the next slide? Okay, thank you. So the questions here is, when should we think about hyper-IgE syndromes? and we will try to answer it today. Hyper-IgE syndromes is a rare primary immunodeficiency syndrome characterized by recurrent severe infection of the skin, lungs, viscera, and greatly elevated level of serum IgE. It was first described as CHOP syndromes in 1966 by David in 2 girls with recurrent pneumonia, eczema, and skin cold abscesses. In 1972, the syndrome was refined and clarified by Berkeley, and he found that in CHOP syndromes, patients will have extremely high IgE level and had a very special facial appearance. In 2004, Greener reported the first cases of AR-HIES syndromes. This means that nearly 40 years after the first case of AD hyper-IgE syndromes. In 2007, Hoang found STAT3 mutation in AD hyper-IgE syndromes, and 2 years later, Nguyen found DOCK8 mutation in AR hyper-IgE syndromes. There are 2 major types of hyper-IgE syndromes. Can you go to next slide? Yeah, thank you. There are 2 major types of hyper-IgE syndromes, autosomal dominant and autosomal recessive. In AD hyper-IgE syndromes has heterozygous dominant negative mutation in gene STAT3. And STAT3 is a gene that has to control the cell proliferation, migration, and apoptosis. Can you come to next slide? In AD hyper-IgE syndromes, the patient is significant with recurrent staphylococcal skin abscesses, recurrent pneumonia. The patient will have unusual facial features like you can see in the picture, such as facial asymmetry, broad nose, deep set eyes, and a prominent forehead. In immunologic assessment, we will find that serum IgE level more than 10 times the upper normal limit. And we also found the normal circulating T cells and B cells. Can you go to the next slide, please? Thank you. On the other hand, autosomal recessive hyper-IgE syndromes is caused by homozygous or compound heterozygous loss of function mutation in many different genes. The most common is DOCK8 gene, accounting for 70% of AR hyper-IgE syndromes. And its genes controls many cellular processes, including migration, phagocytosis, and adhesion. All the genes are TYK2, PGM3, SPINK5, ZNF341, and interleukin-6 receptor. Can you go to the next slide? Yeah. Patients with AR hyper-IgE syndromes commonly have a severe skin viral infection, severe allergy, frequent neurologic complication, early death, maybe because of infection or early malignancy. And unlike AD hyper-IgE syndromes, patients with AR hyper-IgE syndromes will not have skeletal or dental abnormality. In immunologic assessment, will show that the patient have elevated IgE and low IgG, reduced circulating T cells and B cells, and extremely high eosinophilia. So this slide is about the mechanism of DOCK8 deficiency in AR hyper-IgE syndromes. But first, I want to clarify that not all cases, but the vast majority of DOCK8 deficiency in syndromes are associated with elevated serum IgE, so that the term DOCK8 immunodeficiency syndromes was initially referred to AR hyper-IgE syndromes. So you can look in the picture. First, normally following the viral infection of the skin, dendritic cells will take up antigen and travel to the afferent lymphatic to the lymph node where they form T cells. and responding T cells will differentiate and go and travel through the efferent lymphatic to the blood, where they go to various tissues, including the dermis of the skin. So in DOCT8 immunodeficiency syndromes, dendritic cells and T cell differentiate was defected, and combination with the cytokines imbalance, it will lead to increase in viral replication, atopic dermatitis, and mucocutaneous candidiasis. And that is the mechanisms of viral susceptibility and other skin manifestation of AR-HIES syndrome. So now let's move to the second objective, to determine the roles of genetic testing in AR-HIES syndromes. So in 2021, the World Allergy Organization published a practical guide for allergists about the inborn errors of immunity with atopic phenotype. So if a patient has suggested history and presentation of atopic phenotype, first we should approach with the physical examination, the complete blood count, immunoglobulin panel, basic immune phenotype, and allergy test. Second, we should consider the presence of red flag. Can you click 2 times? So I will show you the red flag symptoms. Yeah, and one more, please. So in the red flag symptoms, we will have the serum IgE total more than 2,000, especially in the first 3 months of life, neonatal erythroderma and congenital ichthyosis. And after rule out the life-threatening condition, we will assess the further specific clinical and immunological feature. So when patient has a persistently high IgE level, we should think about hyper-IgE syndromes and use genetic testing to confirm the diagnosis. And we can use whole exome sequencing or whole genome sequencing. Please go to the next slide. This is the summarized table of common genes in AR-HIES syndromes. Each of them will have different clinical features to distinguish from common allergic disorder. However, it's a little bit too detailed, so you can come back to read it later. Yeah, so please go to the next slide. So last but not least, we will talk about the biologic use in AR-HIES syndrome treatment. So for the management should be based on screening and treatment of complication, immunoprophylaxis, and hematopoietic stem cell transplantation. Anti-IgE therapy with omalizumab can be considered as a targeted treatment for these syndromes. Omalizumab is a monoclonal antibody that it binds selectively to the key allergic reaction mediator IgE. It reduces the level of free IgE and prevents the binding of IgE to the IgE receptor on mast cells and basophil. Omalizumab was approved by the FDA 20 years ago for the treatment of moderate to severe allergic asthma that cannot be controlled by inhaled corticosteroid. And it also had benefit in treatment of allergic rhinitis, atopic dermatitis, chronic urticaria, and severe food allergy. So there are many case reports about omalizumab use in both AD and AR-HIES syndromes. Can you go to the next slide, please? Yeah, and you can see here there's so many different case reports about the use of omalizumab. And although costly, omalizumab showed that they have a benefit in patients with hyper-IgE syndromes. Yeah, and that is my presentation today. We have just discussed about a case report about AR hyper-IgE syndromes. So it is a relatively rare primary immunodeficiency syndromes. Can you go back to the previous slide? Yeah. So the take-home message today, AR hyper-IgE syndromes is a relatively rare primary immunodeficiency syndromes characterized by recurrent viral infection, atopic dermatitis, severe allergies, and early onset of malignancy. AR hyper-IgE syndromes caused by homozygous or compound heterozygous loss of function, mutation in some genes, such as DOCT8 and TYK2 and some others. To diagnosis should be based on clinical feature, immunologic laboratory finding, and confirmed by matrix genetic analysis. Anti-IgE therapy with omalizumab should be considered as a targeted treatment for these syndromes. Yeah, and can you go to the next slide? So, and that's all my presentation. So sorry about some technical issues. And I want to send my appreciate to Professor Ruby and Dr. Nguyen for encouraging me to overcome my fear as a junior doctor to take this day and to present today. I also want to thank Dr. Dĩnh, my supervisor, and the faculty team in Vinh University and Vinmec Hospital for all of the support in my pathway to become a better doctor. Yeah, and thank you so much for your attention.
Okay, thank you very much, Dr. Nguyen. And now may I request all our speakers to open their mics and their videos for the Q&A session. We have a lot of questions, and Professor Ruby is joining us for the panel to help support our panel. So let me ask the first question to Dr. Phuc. Okay. There was a very interesting question about screening. If a person or a patient underwent screening tests and all were negative, this is a common concern. What do we say to the patients when they ask what is the underlying cause of my chronic urticaria?
I think first of all, in most cases, when it comes to investigating or assessing chronic urticaria, limited investigations apply. The reason why we're doing specific blood tests is mainly to look at the prognostic factors or prognosticate the condition. And many of the time, you can't really pin down to a single cause like food allergy. You just have to tell the patient that this is not a food allergy, this is not related to some pollen allergy. It's a chronic condition that comes with a fleeting nature. It comes and goes. And obviously, from time to time, you encounter certain aggravating factors exacerbating underlying urticaria, like what we talked about before, like non-steroidal anti-inflammatory drugs like ibuprofen. So as long as a patient knows what to avoid, that should be part of the discussion with the patient in the clinic setting. Yeah.
What if the patient has really chronic spontaneous urticaria without an underlying cause? What would be the best way that we can explain this to our patient?
I think you can explain in a very layman term that this is related to an autoimmunity. That's one of the possibilities, or autoallergy. Obviously, make it in a very simplified manner that is not related to a definitive allergic process, such as external allergen. Yeah. Okay. And I think it's important for the patient to understand, to be adherent to the treatment course. Yeah.
Yes, thank you very much. Okay, now may I go to Dr. Pham?
Yes.
Okay, so you've discussed about the fact that some use of long-term steroids can actually affect the filaggrin levels in patients. But in patients who have severe atopic dermatitis, how can you reconcile that they may need to take long-term steroids, but this may be detrimental to their condition? So what can you, how can you explain this to the patient?
Thank you, Professor Mauricia, and thank you for the questions. Yes, when I found that the corticosteroid can suppress the expression of pigment in the skin, I was a little bit have the same concern with you, that because in some case of AD, especially moderate and severe AD, we have to use the corticosteroid, topical corticosteroid for a long time. And yes, we have to put in the balance. We have to consider about we consider the ratio between the benefit and the risk. And in the case that we need to use corticosteroid, help to control the AD symptom. And even though we can switch to, actually, any doctor, in my case, try to not use corticosteroid for a very long time if it cannot control the disease well. We can switch to another anti-inflammatory medicine, for example, tacrolimus, calcineurin inhibitor, tacrolimus, for example, for the children, or even though we have to use a systemic immunosuppressor for the children with the severe AD instead of using corticosteroid. And again, we have to always consider the ratio between the risk and the benefits.
Yes, so that's very good advice. And we see that patients also have severe atopic dermatitis may need multidisciplinary treatment with a dermatologist for maybe UV therapy to spare the steroids, especially if they are already reacting to the steroids. Okay, thank you for that, Dr. Pham. Now, can I ask a question to Dr. Nguyen? Hello. You have recommended omalizumab for Autosomal Recessive Hyper-IgE Syndrome. But we know that in patients with hyper-IgE, the IgE levels are very elevated. And in asthma, when we give omalizumab with very high IgE levels, it may not be effective. So why is it recommended for patients whose IgE levels are very high, let's see in hyper-IgE? Maybe is there another monoclonal that may be better, like dupilumab?
So thank you for your questions. To be honest, I'm not an expert in using omalizumab and other biologics in treatment of AR-HIES syndromes. So the use of omalizumab is because of it shows there are so many benefits in other symptoms associated with the high level of IgE. For example, in allergic rhinitis or in asthma or in atopic dermatitis. And I have looked up up to that, and in many different articles, like I showed it before. Some of the previous doctor, they had applied omalizumab in a treatment, and they show successful. And about other biologics, I think here with me, I have Dr. Dinh, he's my supervisor, and I think he has more experience in treatment in that syndromes. So Dr. Dinh, I would like to invite you to answer this question.
Yeah, thank you so much for the question. It's very interesting question because I understand that very high IgE level in serum is very difficult to get to compare with the guideline for using anti-IgE in patients with asthma. But in my patient is very high IgE in serum. So that the first question when we consider using anti-IgE for this patient, but when we do literature review and we do for the many cases, they reported successfully with the anti-IgE therapy. So that's the reason why we try to use and you know, pending evidence for the using anti-IgE in other conditions, not only for asthma but also for other kind of disease like autoimmune bullous disease, for example. So we try to use based on that evidence.
Okay, thank you for your answer. And may I also ask Dr. Jason about his experience on omalizumab for chronic urticaria. have you had good experiences with this? And have you had less patients that you needed to give cyclosporin? What about incidence of anaphylaxis? Have you had a lot of patients who have anaphylaxis to omalizumab for the indication of chronic spontaneous urticaria?
Thank you for the questions. So in my clinic, patients who fail to respond to fourfold second-generation antihistamines have since moved on to using omalizumab. And I have to say, all of them achieve a very remarkable and satisfactory response to omalizumab. And when it comes to anaphylaxis, I personally haven't actually encountered a case of anaphylaxis induced by omalizumab. But bearing in mind from my reading, I think there was a task force established back in maybe early 2000s in the States, which look at the risk of omalizumab inducing anaphylaxis. From memory, I think it quotes a risk of 0.09%, yeah, but I think need to look it up, yeah. But in my clinic, I haven't actually encountered anyone developing anaphylaxis arising from omalizumab, yeah. But I think putting this aside, I mean nowadays, you know, there's sort of a heightened awareness about excipient allergy. So sometimes it's worthwhile to consider whether or not the anaphylaxis sustained by the specific patient is indeed due to omalizumab or some other monoclonal antibody, or in fact is due to the excipient itself. Yeah, just one of the consideration to take into factor. Lastly, the third part of the question, I haven't actually needed to explore the use of cyclosporin. Yeah. Yeah, so I can't speak on their behalf. Yeah.
Okay, yes, actually we have the same experience, but unlike you, I've had to be an unfortunate experience of having two patients who developed anaphylaxis already to omalizumab. So, you know, sometimes there are risk factors for this, and they said that it is a previous episode of anaphylaxis that can render them more susceptible to anaphylaxis to omalizumab. Okay, so may I ask Dr. Pham the next question. There was a lot of reaction about your slide on the moisturizers, the discrepancy, that controversy or paradox between giving more moisturizer and having more allergies or getting more symptomatic. And is there any particular type of moisturizer then that would you recommend? Or do you per se advocate the use of moisturizers in patients with atopic dermatitis?
Yes, thank you for a very good question. And usually good questions are very hard to answer. Even though to me, actually when I read that article, I was a little bit shocked because we all doctors usually advise the patients to apply the moisturizer frequently for the baby with AD. And in that study, they just did a survey, and they saw that many moisturizer was used by the parents, from the oil like coconut oil, sunflower oil, or from the many forms of moisturizer, from lotion, ointment, and so on. So many kinds of moisturizer was used. It's not specific for any moisturizer. We don't have any conclusion which moisturizer should be used to prevent a food allergy. And about the advice, indeed, many previous studies shows that if we treat the patient with AD with a right way, apply the moisturizer frequently, it can help to prevent the food allergy. So it's like controversy. And this is just only one study. So I think more study, more specific about the kind of moisturizer used and the relationship with the increased food allergy should be done to see the underlying mechanism of that fighting. In my case, I still should advise the patients to apply the moisturizer for AD children. But in my opinion, I think we have to advise them to wash their hand carefully before applying the moisturizer onto the skin. Because if their hand have some particle of food and they apply the moisturizer onto the skin, the moisturizer could be facilitate for the infiltration of the food through the skin and can cause food allergy. The second thing I should think about it, and that whether we should avoid the moisturizer with the natural fruit or natural cereal substances. For example, it made from avocado, it made from coconut oil, it made from oatmeal, for example, to prevent the food allergy. So I think more study needed.
Yes, definitely. I per se am a moisturizer prescriber, so we have to see more. Okay, for Dr. Nguyen, so now you have a patient, let's say with moderate atopic dermatitis. Are there certain types of atopic dermatitis that you may have to request for immunologic screening? Can you give us some red flags?
Yeah, okay, so this is a very good question. So did you remember about the algorithms that I gave you before? So if you look in the article of WOW, you will see how they provide very significant feature that make us to have further tests for assessment. So if a patient, maybe childhood with moderate atopic dermatitis, but they have some suggest features such as like the patient have a history of recurrent infection, or the patient have family member have immunodeficiency symptoms. So we should think about immuno problems of the patient and do some further tests. We should begin with first with physical examination and some baseline tests like CDC or IgE panel or some T cells, for example. And then if the results show there's some abnormality, we will follow that and to make some further tests like atopic screening test or some IgE, specific IgE or the gene test later.
Okay, thank you very much. You know, there's so many questions that are left unanswered, and they're very important questions. So I'm sure our panelists will be able to answer them online and put it in the www.apaaci.org site. So those who ask the questions, you will see your answers there. And me now turn over the floor to Professor Ruby Pangwangkar to help us close this session. Thank you for your attention, everyone.
Thank you very much, Professor Marisa, and thank you very much to Dr. Jason Pham, Dr. Diu Le Pham, and Dr. Kim Han for the excellent lectures that you have given. I think it was very, very informative, educative, and also state-of-the-art. Thanks also for answering all the questions, and thank you, Professor Rector, for the excellent moderation of this important webinar. I wish we had more time with so many questions. I'm also dying to ask some questions, but I will keep it. So as Professor Rector said, please be sure, we thank all the participants for being there. Thank you very much. And we look forward to your continued presence in our various master classes. Please be rest assured that all your questions will be answered by the speakers. We will put it up on the APAACI website for you to be able to see it. So please hold on for a few days and you will have your answers. And before I would end my end this session, I'd like to just thank also our secretariat for all the work that they have done in helping, and especially also thanking our partner who has supported this important APAACI Masterclass, Menarini, who has actually really supported us very, very much into making this and especially highlighting the stars of our region. These are the leaders that will take us into the future. So we are like with the stars of our region. So before I'd like to end, I just try to say, watch out for the next APAACI Masterclass. It's coming very soon. It's on the 29th of March, the same time as today. It is going to be with top speakers, also young speakers, and also established speakers. And it is going to be on hereditary angioedema, current updates on hereditary angioedema. So please stay tuned and please join us for the APAACI Masterclass on March 29. And I would also like to bring to your attention a very important event for APAACI. It's most important event is APAACI 2022. Many of you may have attended APAACI International Conference 2021. This is going to be a live meeting, live Congress in Manila on the 5th to the 8th of December 2022. And it is going to be on evidence-based integrated care in allergy, asthma, and immunology, together with the Philippine Society of Allergy, Asthma, and Immunology. It is going to be their golden jubilee, so it's going to be a big celebration. Please join us there in person, and we look forward to welcoming you there, both as APAACI and as PASI. On behalf also of Professor Romel Lobo, the current president of PASI, and Professor Marisa Recto, the immediate past president, and all the PASI board members and all the APAACI board members, I welcome you to APAACI 2022 PASI at 50. Thank you very much. Have a good evening, have a good afternoon, and have a good night.